Okay, I think most of us are in now, so wonderful that you could all join for this very important forum. This is the second in a series of 4, and as you will all be aware, we had planned for a face-to-face stillbirth forum, which the topic of tonight's webinar is the reason why we haven't been able to do our face-to-face meeting. So we are doing our series of 4 webinars. This is number 2, and the topic is about COVID-19 and pregnancy and perinatal care. Right, so I'd like to start off with acknowledgement. I'd like to respectfully acknowledge the traditional owners of the land and sea on which this event is taking place. I also acknowledge elders both past and present, and that their cultural and heritage beliefs are still as important to them today. I also recognise those whose ongoing effort to protect and promote Aboriginal and Torres Strait Islander cultures will leave a lasting legacy for future elders and leaders. So last year we were meeting in Brisbane and we had 250 attendees. The webinars have also so far attracted a lot of attendees, so I think apart from all of the differences that COVID-19 is making, we're finding new ways to do things, and the webinar series appear to be attracting about the same number, if not more people. So today we are hoping that we can get this latest information to you in a very accessible way and that you find it very useful. So we've had one webinar already last week about the Safer Baby Bundle, and all of these webinars will be recorded. So webinar 1, 3 and 4 will be available in a couple of weeks. Our seminar today, which will be recorded, will be available early next week because of the topical nature of COVID-19. So we're going to have a number of polls. We're also going to do questions and answers at the end of each presentation, and then we will address those at the end of everyone's presentation, unless there are pressing answers that we can give on the way. And just a reminder, please complete the exit survey. So that's giving you an indication of entering your questions in the Q&A section, which you can find the little double balloons in the middle of the bottom of your screen is the way to enter your question or questions. Okay, so webinar 2 is entitled COVID-19 changes to maternity practice, just a small little topic, and we are very, very privileged to have 3 wonderful speakers who all happen to be on the COVID-19 Taskforce in several capacities, including on the pregnancy and perinatal care panel. I'm a member of that too. I'm also on the Stillbirth CRE executive, and I work at SAMRI Women and Kids in Adelaide and based at the Women's and Children's Hospital in Adelaide. So our presenters today, you'll hear from them each in turn. First off the rank will be Dr. Claire Whitehead, who's a Senior Research Fellow in Obstetrics and Gynaecology at the Pregnancy Research Centre at the Royal Women's in Victoria. Second will be Associate Professor Joshua Vogel, Principal Research Fellow, Maternal and Child Health at Burnet, and Professor Caroline Homer, who's the Co-Program Director of Maternal Child Health, also at the Burnet. I also would like to recognise and acknowledge that this is the International Year of the Nurses and Midwives, and also want to let you know that we have got a system for accreditation points for continuing education So I don't think that was available last week, but now we have that in place. Okay, I'd like to ask Claire to start with her overview of telling us all about maternity care practices and the latest information from COVID-19 in pregnancy. What's happening? So thank you, Claire.
Thanks, Philippa. So this is a bit of a whistle-stop tour of COVID-19 and what it means for mothers and babies. It's based on the literature that's come out in the last few weeks, and obviously this is a currently evolving space. So it may well have even changed since I wrote this yesterday. So I'm happy to update as we go, and I've been involved in a number of international groups and know a little bit about what's coming in the media, not just in the literature, not just what's happening now. But thank you for the opportunity to present this today, and I'm happy to take questions at the end about anything that's discussed. So as we all know, pregnancy is a time of great change for the mother. There's immunological and cardiorespiratory changes that may predispose a mum to more severe respiratory infections during pregnancy. And we've seen that in the past with MERS, SARS-CoV-1, H1N1, that there's been increased case fatality rates in pregnant women compared to non-pregnant women. And there's also a number of other things that we need to consider in terms of the care of the mother if they do become severely unwell, in terms of things such as airway management and ICU that would be different from a non-pregnant individual. There's also the risks to the unborn child, and so that's both prematurity and as well as risks of potential vertical transmission. And so these are the kind of topics that I'll cover for you today. We just start at the beginning and think about the prevalence of COVID-19 during pregnancy. It doesn't appear to be particularly different to non-pregnant women. And so this data is somewhat challenging to interpret in terms of how that data is obtained. So the two sort of typical approaches have been either hospitals doing universal screening of all women presenting, and so that was certainly the case in New York in the middle of their pandemic, or it's just screening of symptomatic women. And so the rates do change depending on what screening approach you take, but somewhere between 3 and 30% of symptomatic women have had a positive result. This is no different, as I say, from the non-pregnant group, and so this is admitted patients in the UK in the early part of the data, and you can of the pandemic, and you can see that women of a reproductive age are represented there, and therefore we would expect women that are pregnant to be represented at the same time. Of those people that do develop disease, about 85% of them will just experience a mild or moderate disease, although recognizing that those with moderate disease may require hospital admission. 15% will develop more severe disease, and 1% will develop critical disease. How do they present? Well, again, very typically to the non-pregnant population. So the most common symptoms that people will present with will be fever and cough. And this is data taken from the UK registry or UK surveillance system. And out with that, they didn't include anosmia, but about 22% of people were presenting with a loss of smell or taste as well. Majority of the data that I'm presenting today are from these large data sets. So the UCAS data that was published in the BMJ, there's a large systematic review published by Asma Khalil that looks at over 2,500 pregnant women with disease, and then I'll touch on the CDC data as well. So you'll see the references at the bottom, but the data is a combination of those. And this particular figure comes from the UK data. When we look at investigations performed on mothers during their admission with COVID-19, about 85% of them will have a raised D-dimer. This is not looking at pregnancy-specific ranges. So as we know, in pregnancy, D-dimers are raised anyway, but certainly those with COVID do appear to have an additional rise beyond that. About 50% will have raised inflammatory markers, as typically a lymphopenia. There was initial concerns about the rates of thrombocytopenia, especially in the implications around the time of delivery, but that appears to be quite low rates, although it is present, especially in those with severe disease. And liver dysfunction is present in about 16%. Rates of chest infiltrates, so in keeping with the viral pneumonia, are high, but again, that reflects the testing that's done on this population. When we look at risk factors for getting disease, so again, looking largely at the UK data and the data coming out of the US, the majority of women that were in this initial sets of data didn't get disease or didn't need to present to hospital until they were in the 3rd trimester of pregnancy. So not appearing to affect the earlier trimesters to such an extent. There is a significant disproportion in terms of people of different ethnic origins being more at risk. And so in the UK, Asian and Black ethnic origin women were more at risk, and that's accounted for about 50% of their population. And if we look at the US data, it's largely represented by Hispanic ethnicities, and they predominantly seem to be more affected, as well as within the Black ethnic groups as well. So a predominance for these groups compared to others. And many reasons why that may be. There's also higher rates in women with who are overweight or obese, and those with pre-existing comorbidities. And again, this has been a little bit tricky to pull out from the data as to what these may be. So certainly hypertension, diabetes, and cardiac disease seem to be overrepresented. But whether this is gestational hypertension and diabetes, or whether it's pre-gestational, the data hasn't really been clear. If we look at those that develop severe disease, so again, looking at the UK and the CDC data, because these are probably the most relevant here. So overall, there appear to be about 10% in the UK data and in the systematic review that require level 3 critical care, so essentially ICU level care. Within that, about 4% required mechanical ventilation, or well, 4% overall, not within the 10%, 4% of the population required mechanical ventilation, and just under 1% required ECMO. And in the UK data, this led to a case fatality rate of about 1.2%. There are some challenges in interpreting the CDC data. So the CDC data that was published on the 26th of June as part of their Morbidity and Mortality Weekly Report focused on the pregnant women that had been reported within their surveillance study. There is a lot of missing data, and there is not a lot of clear data about actually trying to interpret what this may mean. But essentially, they had just over 8,000 pregnant women. 30% of them were hospitalized whilst COVID positive, but some of them would have been hospitalized for intrapartum care, not necessarily because of their COVID disease. But within that cohort, about 1.5% of them, so lower numbers, required an ICU admission. But this was 50% higher than non-pregnant women of the same age group. And again, the relative risk of requiring mechanical ventilation was increased. So that was 1.7 as well, so 70% increase. But their overall case fatality rate was much lower than other studies, or certainly lower than the UK data, with only a 0.2% case fatality rate. And that was no different from pregnant women. So more people going to ICU, potentially needing ventilated, but less, or the same deaths. The other challenge here is it doesn't tell us if those ICU admissions were for COVID or if they were for other obstetric indications, such as preeclampsia, large PPHs. So we are unable to pull that out from this data. At the bottom, this is the current CDC track record, I guess. So currently they have in their surveillance system 12,000 pregnant women, or nearly 13,000 pregnant women, of which 3,500 have been hospitalized, and within that there have only been 35 deaths. So again, very reassuring in terms of low death rates, and relatively few needing hospitalization, but important to look at. One of the other challenges, as I say, in terms of interpreting the data is what did these people actually pass away from, where there was mortality rates, and we haven't had a lot of clarity about that. Again, was it a hypoxic injury or something else? And so I was on a call with Marion Knight last night, and I believe they're going to publish some of the UK data in terms of what the details of the maternal mortalities were in the next week, hopefully, and so we'll get a bit more clarity to be able to understand that. How do we treat mothers that do get COVID disease during pregnancy? And so this is a personal passion project of mine at the moment to try and increase access to treatments for pregnant women, or at least access to clinical trials to evaluate them. And so we've been working both locally and internationally to try and advance this. But currently, if you look at the international clinical trial registries, there are more than 1,500 clinical trials currently registered for therapeutics for COVID-19 or for vaccines. Many of the drugs that are being included in these have good safety profiles in pregnancy, and we use them routinely for other pregnancy conditions. But currently, of that 1,500, there are only 4 that are actively recruiting pregnant women. In Australia, we're lucky that we do have one. So the REMAP-CAP is a long-standing, not just COVID-related study that's looking at women, or looking at people admitted to the ICU and various different treatment options for them. So pregnant women are included with that, but they are excluded from antiviral treatments within this and some of their other treatment domains. So we still have work to do on that. The two big international trials that are currently recruiting pregnant women are Recovery, led from the UK, and then the WHO Solidarity Study, although the details from WHO in terms of how they're recruiting pregnant women is not that clear at the moment. And then I highlight ASCOT, which is an Australasian study and is expanding to international sites. And we're currently working with their PIs to include pregnant women in that, and they will be eligible to be randomized to safe and appropriate treatments, hopefully in due course. One of the challenges is if we don't recruit women, we won't have information, and there's currently no systematic approach to collecting exposure data outside trials, and that means we are unable to develop any information about safety or efficacy of these in our population, and that does limit how well we're able to provide guidelines for our population. And Josh will talk a little bit more about this moving forward, but we have to essentially extrapolate from adult non-pregnant trials. And so the two main drugs that we would talk about at the moment, so would be remdesivir and dexamethasone. So remdesivir is an antiviral treatment that has shown promise in the non-pregnant adults for those requiring hospitalization in reducing the length of stay, not shown any benefit in terms of mortality. Pregnant women were not included in this top study that was recently published by Beagle in the New England Journal. And the only data we actually have that's published about remdesivir in pregnant women is from this study from 2019 that recruited pregnant women for treatment for Ebola virus. And there were only 6 women included pregnant women included in that trial. We do have remdesivir available in Australia as part of a compassionate use program, but the stock is very limited and therefore actually accessibility to it may be a challenge for us to understand. If we look internationally, about 20% of pregnant women have received treatment with antivirals, but it's unclear which, and certainly a large majority of them probably were hydroxychloroquine in the setting of the US, and the initial enthusiasm for that, although some pregnant women have been receiving remdesivir. More promising is dexamethasone, which has shown benefit in mortality. So in those women, those individuals who require hospitalization and ICU admission specifically for the severe end of disease, there is a reduction in mortality at day 28 in those that were given dexamethasone compared to usual care. Again, we can't provide information directly about pregnant women. This has come from the Recovery trial, which did include pregnant women, but there were only very small numbers, and they currently only have 18 pregnant women currently enrolled in that trial. So again, we have to extrapolate this from non-pregnant patients, but we know that dexamethasone is safe, and therefore this is appropriate to use in this population. In terms of pregnancy outcomes, so specifically for this audience and the Stillbirth CRE, if we look at pregnancy loss, there appeared to be in the UK and the larger systematic reviews about a 1% miscarriage rate, which is no greater than baseline. There was a 1% stillbirth rate, so that was higher than you would expect for the population, and about 1 in 200 neonatal deaths. But if we pull apart, there are small numbers. Many of these appeared to be deaths with COVID rather than deaths from COVID, and that's an important distinction to make, that they can't be directly linked to COVID infection. We looked at rates of prematurity. The rates of prematurity for COVID infected women are quite high. So between 20 to 25% of women will have a baby less than 37 weeks, and 10% of them have delivered prior to 32 weeks, so very preterm. Pulling apart that data a little bit more, 10% have a spontaneous preterm birth, which again is not particularly different from what we would expect in the population, just very slightly higher. There is a higher rate of PPROM and then ongoing need for delivery. But the majority of deliveries in this premature group were medically indicated, many of which were due to concerns about maternal compromise and therefore the need for delivery, with the remainder either being due to fetal compromise, which may be due to COVID, or other obstetric indications such as preeclampsia or fetal growth restriction. How do the babies come out? Well, about 50 to 60% of them are being delivered by cesarean section. A quarter of these are due to concerns about maternal compromise, and therefore the need for a cesarean rather than being allowed to labour, and this includes things such as respiratory compromise or inability to tolerate pushing or tolerate labour. The others are either for fetal compromise or standard obstetric reasons. The higher rates that we also see is with an increased rate of need for general anaesthesia. Again, this was largely due to concerns about maternal respiratory compromise, and some of these women would have remained ventilated afterwards, or at least for a short period of time. And some of them were due to standard indications and need to expedite delivery, but also challenges around the use of PPE and the time that it takes to adequately perform an emergent caesarean section. Probably one of the areas of the most limited data and concerns about controversy, I guess, is in terms of newborn care and how we address that both in terms of systems level and then at an individual level. So I've divided this nice infographic up that's been published in the American Journal of Perinatology into those that kind of affect the mother and looking at vertical transmission, and then those that affect the service and the how babies are cared for more in the neonatal unit rather than on the postnatal ward. But these are some of the things that we need to consider in terms of how we provide care to reduce the risk of transmission to a baby, both from the mother as well as from other healthcare workers. And so if we look at the risk of mother-to-child transmission, there appears to be, on a whole, about a 4 to 5% rate of confirmed neonatal infection, of which half of that appears to happen early within the first 24 hours. And one of the challenges in terms of interpreting the data is that there has been very limited testing. And so we don't know whether other babies are affected, because if we don't test, we don't know. And then interpreting when the infection may have occurred. Again, the data has not been robust in terms of providing us with information about this. Prakash Shah has proposed, and his team has proposed, a classification system to help us to define when SARS-CoV infection does occur. And although this is a little bit cumbersome, it's probably important to think about in terms of service delivery and how we address this, because it may affect how we can move forward if we find that one particular area is more important. So congenital infection, that which is acquired within the womb, can be demonstrated by PCR positive cord blood or neonatal blood immediately after delivery, or in the amniotic fluid prior to rupture of membranes. This is in contrast to intrapartum acquired infection, which would be a positive nasopharyngeal swab in the baby at birth or within the first 24 to 48 hours of life, or those which are postpartum acquired, so acquired from close contact with an infected mother, and that would be a positive swab after 48 hours of birth with a negative swab at birth. There doesn't appear to be an effective mode of delivery on terms of the risk of intrapartum acquired disease, and obviously practices around the neonatal care may affect postpartum acquired. But just touching on the kind of intrauterine acquisition of neonatal COVID infection, there's only really been one good, robust paper that was very recently published in Nature Communications, which very nicely took a number of samples, both from the mother and the baby at various different time points, as well as providing some clinical information. So this was a case report of a 23-year-old from France, published by Daniel DeLuca. She was 35 weeks pregnant, presented with COVID symptoms, PCR positive, and was admitted and subsequently developed fetal distress requiring emergency caesarean section. She had intact membranes at the time of caesarean section. And so from a maternal point of view, she had a positive nasopharyngeal swab, and the mother was viremic. Amniotic fluid was collected at caesarean section prior to the rupture of membranes, and that also demonstrated SARS-CoV-2 within the amniotic fluid, and this was present in the placenta. It was present in the vagina, but at very low levels, again reflecting that that wasn't likely to be the source of infection as an ascending infection. From a neonatal point of view, the baby had blood collected at birth, as well as nasopharyngeal swabs, all of which were positive, and the baby developed more virus over the first couple of days of life. The placenta was sent for histopathology and showed massive perivillous infiltration and some intervillocytis, and the bottom image shows protein staining for SARS-CoV-2 on the syncytial trophoblast. Unfortunately, this baby was symptomatic, required a neonatal unit admission, and did develop some neurological sequelae prior to being discharged home well. But it's very challenging to determine whether this was due to SARS-CoV infection, or in fact whether this was due to the primary placental pathology, and where, as we know, that we would see neurological changes in a baby that is born from a placenta that has perivillous have fibrin deposition. So I would caution the interpretation of this. The majority of babies that have been born and been positive for SARS-CoV-2 have done very well and not required neonatal care or become unwell. But this is an important case report to show what can happen. If we look more at a more useful data set, this is looking at a cohort study from New York that has just been published in the last week. So this was from 4 New York hospitals in the middle of the pandemic that struck there. They had 116 mothers that were positive at the time of delivery and delivered 120 neonates, of which they were able to follow up most of them, but there was some drop off. But these babies were tested at day 1, 5, between 5 and 7, and day 14. And if we look at the practice that was done, it's very similar to what we're currently thinking about doing or currently doing in Australia. So the majority of these babies roomed in with their mother. Those babies that needed a NICU admission were primarily for neonatal concerns, rather than were largely not COVID related, such as prematurity, and the mothers largely breastfed, and that continued until 1 month of age. They went home to a household where there was potentially another infected household member. The mother was encouraged to use mask and hand hygiene as we would recommend. They were very good at hand hygiene. Not quite so good at the mask, but overall numbers were pretty good. But very reassuringly, we can see that over that 14 days of life in this cohort study, none of the babies tested positive. And obviously there was some loss to follow up in those discharge data, but there were none positive within the first 24 hours of life, suggesting no intrauterine or birth acquired infection, and certainly those that were able to be followed up were reassuring that this practice that we're currently recommending is reasonable. But yet there are many unanswered questions, and so I would urge you, if you do have cases, to contribute them to data sets so we can understand a lot more about this. I'm working with a team on the Chopin registry, which is at least initially nationally, and we're now recruiting some international sites as well. Recruiting cases within Australia. We've had interest from all the tertiary units, and we're now working with ANZNN to make sure we capture robust neonatal data, and also planning to collaborate with Epicenter on some of the longer term and readmission neonatal data. And then linking this in with other data sets internationally, including those being collected by the WHO in the UK, the US, Europe, and others that are looking to answer specific questions about COVID infection in pregnancy. So I've put the PASANS website down the bottom. If you are not sure if your site is included, or you're not sure if you have ethics, please reach out to us, and we would love to include you, and we can help get you all on board. The other sort of final thing is not just how has COVID affected those women that are actually unwell during pregnancy, but what has the fallout been for our maternity services? And there has been a great deal of interest in the last week, prompted by 2 papers that are currently in preprint and are not yet peer-reviewed or published, but it's certainly been picked up by the media. That potentially there's been a drop in preterm birth rates, either during the lockdown or due to changes in care this year. And so this graph here shows this very dramatic blue line drop to nearly no very low birth weight babies being born in Ireland during early 2020. I think it's too early to really know what this means. We're certainly looking at it in Victoria. We've got an international collaboration also moving forward to try and understand this, whether it's true, and whether what might be driving this if it is. So certainly there's many questions that have come out of this. The other question in terms of care is, has there been an increase in stillbirth rates? So there was this paper came out of St George's in London, looking at their preterm birth and stillbirth rates during the early pandemic, and unfortunately they have shown that there was an increase in stillbirths in their population from 2 to 12 during that time period if you exclude terminations, so a 6-fold increase. And this doesn't appear to be due to COVID infection, but may be due to changes in antenatal care, and so this is important that we do address this as we move forward. And not just medical concerns, but there's also the experience for parents, both with being in isolation, quarantine, or just delivering a child or being pregnant during this time period. So the Stillbirth CRE is involved in this cocoon study, and you can find more details about that on the website. And I urge you to encourage your patients to enrol and provide that information for this international study. And so now I practice in Victoria. We're all wearing masks like this, except without the crown. And our babies haven't quite got to that point yet, but certainly our practice has changed dramatically in the last few weeks as we see more and more pregnant women being affected. And this is important for us to understand as much as we can about this disease. And I'd just like to acknowledge my team that I'm working with, as well as our funding bodies, ANZNN and RANZCOG are also involved. Thank you.
Thank you so much, Claire. That was a wonderful presentation, absolutely full of detail and tantalising pieces of scientific information. So just wonderful to hear. Now we have the amazing Josh Vogel, who has come, I think, been here about a year now. He's a Aussie by background, WA I think, but worked in WHO for some years around evidence and guideline matters. So it's wonderful to have him working in Australia at the Burnet Institute, and one of his many roles is on the COVID panel that we have talked about, and he's a scientific advisor on that panel, very interested in living evidence guidelines, and he's going to tell us all about that. So over to you, Josh.
Thanks, Philippa. I trust I'm audible. Yeah, and visible also. Great. Okay, thanks everyone. Really appreciate the opportunity through the Stillbirth CRE to talk about this, very topical and important issue. Very grateful to Philippa, Chris, Claire, Caroline and the team who have helped make this work. So I'm just going to speak a little bit about the National COVID-19 Clinical Evidence Taskforce. This is a relatively new entity that was set up in March of 2020 to respond to the COVID-19 pandemic in Australia. It's being led by Associate Professor Julian Elliott, who's at Monash, and very closely involved with Cochrane Australia and the Australian Living Evidence Consortium. I just want to speak a little bit about the kind of background of the task force. It's a national entity that's bringing together 29 peak professional bodies across Australia. And the goal is to develop and provide clinicians with living guidance for the clinical care of people with COVID-19. I provide the URL there. If you haven't seen it already, please do check it out. And this is a group that's producing MHMRC guidance on clinical care, but is specifically around the treatment of people with confirmed or suspected COVID-19. That is to say that guidance that pertains to questions of infection prevention and control, or other interventions outside of clinical care that are very relevant to COVID, but aren't necessarily within the scope of this task force. So questions that maybe people have been struggling with in different jurisdictions and different contexts with differing rates of transmission should best defer to their local guidance on those issues. But the idea is to have a one-stop shop for clinical recommendations. One sort of very unusual aspect of the COVID pandemic has just been this escalating volume of research that at times has felt a little bit overwhelming. And I put these slides together a couple of days ago, and they're already out of date, of course. But we've got nearly 12,000 studies in the Cochrane COVID-19 study register. And of the over 1,200 trials that are currently registered on COVID-related interventions, only 2% of those have actually been released. So we have not even yet seen the full volume of research that's going to come out relating to interventions and treatments for COVID-19. On top of that, there's a rapidly growing number, nearly 1,600 systematic reviews that have been registered in Prospero. Unfortunately, quite a lot of duplication in those systematic reviews. So one key message, I think, has been to really ensure we're fostering international collaboration and reducing duplication wherever possible. Certainly there are a number of large groups internationally that are doing very high quality systematic reviews on the major questions, and there really isn't a clear need to duplicate those efforts. Just want to talk a little bit about living guidelines. So this is a model that's relatively new and maybe not too familiar to people who haven't been directly involved. But if you're familiar with the sort of traditional or historical way that guidelines have been developed, you go through this process that we talk about as climbing the mountain. You know, you define your scope, your systematic review is conducted, you convene your expert panel, you spend a lot of months, maybe a year or two, developing your document. You publish it, and unfortunately it may not be updated for quite some time. But what research has shown is that, you know, a lot of guidelines become out of date very quickly, or in some instances even out of date on the day that they're published. The evidence these days is just moving so quickly. On top of that, there may be changes in policies, new products in the market. At some point we may get the resources or the energy to update that guideline, but we have to go through this process all over again. So what this means is that over the course of a guideline's life, it's often out of date, or at least partly not up to date. So that just makes it more difficult for guideline users and clinicians to have a tool that they know is reliable and current. So living guidelines is about trying to come up with a solution to this problem. One still needs to go through that initial process of climbing the mountain and developing your guideline. But rather than sort of putting it out there and forgetting about it, we develop and maintain this ongoing literature surveillance where systematic reviews and evidence syntheses are updated on an ongoing basis. This means that the recommendations can be kept contemporary, up to date, reliable, but also responsive. So if new policies come, if there's new products on the market, we're able to react to that more quickly. Groups and guideline developers who have implemented this model, you know, in some instances this has been maybe looking at the evidence every month, maybe every couple of months. But in the COVID pandemic, you know, we're in a very unique situation. So the living guideline model that we're using is using a sort of much more day-to-day surveillance model. In practice, what that means is that there is a central group of guideline developers and researchers who are surveilling that evidence and synthesising it into systematic reviews on a weekly basis. A series of expert panels are convening every week to review new or updated evidence and adjust recommendations accordingly. And those recommendations are reviewed and endorsed by the member organisations and published online every week. So you can imagine this is at a very high tempo, but certainly appropriate considering the scale of the pandemic. The way the task force is organised is with a series of separate expert panels that are sort of looking at different aspects of the clinical care of people with COVID-19, and the panel is composed of the appropriate experts in those areas. Certainly with a view to gender balance, geographic diversity, and an appropriate multidisciplinary mix. The pregnancy and perinatal care is one panel within this group. We first met in May, middle of May 2020, and have been convening every week since then. On top of that, there's a number of advisory and working groups, and a pool of additional temporary advisors that we can draw on if we have specific challenges with difficult clinical questions. I just want to take a moment to acknowledge and really thank the Pregnancy and Perinatal Care Expert Group. This is a group of volunteers from a range of disciplines, not just obstetrics, midwifery, but also perinatal epidemiology, neonatology, obstetric anaesthesia, and several others. And they have certainly gone above and beyond in making themselves available to review these living syntheses on a weekly basis. So we've been quite pleased with the experience in terms of the rate of output. And we're currently up to version 14 of the guidelines. So that's 14 weekly updates since it was first launched on the 4th of April. We have something like just over 200 people contributing to various aspects of review and updates every week, which we've calculated equates to about 360 hours of volunteer time. So while this effort has financial support, it's very gratefully appreciated from Commonwealth, state government and other donors. It is by and large a voluntary effort. On top of that, there is this escalating number of citations that we on the evidence synthesis side screen and review every week. And we're actually, over time, expanding the scope of the number of interventions that we're able to appraise as well. The latest number we have is that 48 recommendations separately have been published, but of course this will change in the next 24 hours with the update that's coming tomorrow. So in early May, in preparation for the Pregnancy and Perinatal Care Panel meeting, we did this rapid review of maternal and perinatal health recommendations. So our goal was to just sort of say, okay, what's out there at the moment, and what can we identify in terms of areas of high consensus around interventions, but also those areas where it was more controversial, there's more variable guidance, and perhaps areas where we're able to resolve some controversy. And I'm sure people can sort of identify with this experience that, we were really overwhelmed by how much guidance was out there. We found 81 separate guidelines from 49 different organisations. Of course, we're not just looking at Australian or Australasian regional resources. We're also looking at international organisations and other high-income country colleges and societies for guidance. But in large part, there was just a real overwhelming amount of resources there, which I think does make it difficult for people to know what to do and for whom. We have, as a kind of preliminary product, made this list of resources and the recommendations within them available on the Burnet website, so please feel free to check that out. I certainly can't sort of summarise all 90 interventions in one slide, but just to give you a sense of the sort of interventions that are being addressed in those different guidelines. Obviously not all of them in all guidelines, but touching on lots of aspects of COVID-19 prevention, control, treatment across antenatal, intrapartum, postnatal, postpartum care, and as well as assessment and care of unwell women during those periods. And a real sort of challenge has been the importance of emphasising and addressing effective routine care practices, and whether those practices should or should not change, or how they should, how they've been impacted by the COVID-19 pandemic. And I think the volume of guidelines really do illustrate that people were perhaps very unsure about what to do in the early phase of the pandemic. And on top of that, these are often rapid guidance that's produced perhaps without the traditional wide-ranging systematic reviews that we would prefer in a more relaxed context. And on top of that, often in the absence of direct evidence, I think Claire illustrated very well that we're often having to extrapolate evidence from non-pregnant or even non-women populations in guiding this practice. We provided all these findings to the panel and went through a prioritisation process, thinking about not just the scope of the task force, focusing on the clinical care of people with COVID-19, but also, what interventions and recommendations are most critical for care in Australia, and considering what recommendations produced by the task force need to be modified or adjusted, for a pregnant or postpartum population. And that involved a formal ranking exercise on the basis of a likely impact on outcomes, proportion of the population impacted, the extent of variation in practice, and the likelihood of new evidence emerging. I would just direct people to the website if they would like some more detailed information. Of course, we're happy to take questions about specific recommendations, but this evidence is actually quite, these recommendations rather are informed by some of the evidence that Claire presented, particularly the Walker 2020 systematic review. So we have here 3 recommendations on mode of birth, breastfeeding and rooming in. These are based on systematic reviews of largely case series and case reports, which point to the fact that standard care should remain in terms of selection of mode of birth, ensuring that women are supported and encouraged to breastfeed and to room in. However, those women who are infectious with COVID-19 should be using infection control and prevention measures while breastfeeding and rooming in. In terms of interventions for people who are moderately to severely unwell with with COVID-19. We've obviously seen the evidence around dexamethasone, some very compelling effects on reduced mortality, but particularly in those who are receiving oxygen, including mechanical ventilation. However, there does not seem to be any benefit from dexamethasone in those patients who are not requiring oxygen. So, for example, those with mild disease, there doesn't appear to be any benefit. The panels looked at this evidence. There were 6 women in this trial who were pregnant patients, and we don't actually know which arm that they were allocated to, but I think as Claire pointed out, this is a treatment that's commonly used in some pregnant women. Safety profile has been very well described, and there is a clear mortality benefit in patients in the trial. So the panel elected to recommend in favour of its use in those patients receiving oxygen and to not use it routinely in those who do not require oxygen. In remdesivir, we've emphasised the point that pregnant women are often excluded from clinical trials. So while it is still being evaluated in clinical trials, pregnant women may not necessarily get access. But any women who are receiving remdesivir, for example, in the context of compassionate use, should nonetheless be enrolled in at least one or ideally more of those COVID-19 registries that Claire mentioned. And we currently have no direct evidence on the effects of remdesivir in pregnant or breastfeeding women. The panel has a quite extensive work plan of recommendations that they're working through in the coming weeks. So at the moment, recently we've been discussing the use of ECMO in severely and critically unwell pregnant women, as well as prone ventilation and the importance of skin to skin, and also other disease modifying treatments. There is a large number of antivirals, antimalarials, and other treatments that are being trialled. In general, these trials have not many patients yet that have been published, and we're more or less in a space of recommending the need for further research. But as this information becomes available, often through the use of preprints, we're able to incorporate that information rapidly and adjust the recommendations in a very responsive way. There on the right, we have the questions that we will be addressing in the near future over the next several weeks. But just to emphasise that we really do welcome any suggestions or interventions that people feel should be addressed by the panel as it relates to the clinical care of pregnant and postpartum women with COVID-19. Just want to really encourage everyone, do check out the website, please share it with your networks, and please do follow on Twitter at Evidence COVID-19. Every week they're pushing out the new recommendation content, and just yesterday we've released some great video content of Prof. Homer discussing these recent recommendations from the Pregnancy and Perinatal Care panel. So at this stage we really ask for your support in helping to disseminate this important body of work out to our communities. At that website you can subscribe to receive the weekly communique from the task force, so you can stay on top of the recommendations. And on top of that, you can also suggest your interventions or topics that you think really need to be addressed. And each of those suggestions are reviewed by the team every week and discussed with our guideline leadership group. So please do feel that your suggestions will be listened to. Just want to close by acknowledging the 29 member organisations that have made this possible. And I just want to make a very special mention to those colleges, RANSCOG and ACM, that are obviously quite close to our community, who have really been extremely supportive of this effort from the start, even at a time when the task force was still very much in a development phase. And that contribution has made a significant difference to the success of this effort. And of course, very grateful to our funding organisations and partners that make this possible. So thank you very much.
Thank you so much, Josh. That was an excellent overview of what's happening and also a demonstration of living evidence in practice and in evolution. So thank you very, very much. Now, Caroline Homer is going to give us some observations and thoughts on what the other two speakers have presented to us and some thoughts of her own, I think. So we'll let her do that. So over to you, Caroline.
Thanks, Philippa. Thanks, everybody. Great to still see 200 and something people online. I don't have any slides. Just was going to say a few things about direct and indirect effects of COVID. So the work that both Claire, for the most part, has presented, but certainly the work that we're doing in the task force on guidelines is really around the direct effects. Women who have COVID, or this new term, which only discovered this week, called SCOVID, and that's suspected COVID infection. So the task force hasn't focused on indirect effects, and I'm sure for most of the people on this call, apart from those of us in Victoria in a few hospitals, it's the indirect effects that you're mostly grappling with at the moment, and we really recognise and understand that. And it's a hard time for everybody with everything going on and more borders changing even today. I'll come to the questions in a moment, and Philip is going to help me with that as well. But just, there's a lot of research going on across the country. I just wanted to give you a smattering of the kind of work that's happening across the country. We've got an incredible bunch of researchers and clinicians and scientists and epidemiologists and all sorts of people who've come together. So Claire talked about the registries and Chopin and the other registries in Australia. I know a little bit more about the Victorian research because I'm here, and we've also established a Victorian perinatal COVID-19 research network through COPM, the Consultative Council for Maternal Obstetric Morbidity and Mortality. I'm never very good at the letters. And we're looking at things like indirect effects. So particularly we'll be looking at national, state firstly, and then national data of looking at stillbirths and preterm births and intrauterine growth restriction to try and work out whether the indirect effects on the population have made a big difference. There's also a lot of research going on in Victoria, and I'm sure in other states, around telehealth and the evaluations of telehealth, both from the clinical implications for the women, also women's experiences, clinicians' experiences, and cost effectiveness. There's also research going on the impact on staff, on for us, midwives, doctors, midwifery students, medical students. There's a few studies, one called COVMAT, that is a national study rolled out from Curtin University in Western Australia that's just finishing up recruitment. We've looked at midwives, doctors, women, partners, and midwifery students. There's also a qualitative study we're doing in Victoria, tracking the experience of leaders in maternity services to find out their experience over these 3, 4, 5, however long, many months it goes. Very interested in women's experiences. And so Claire mentioned Cocoon. We're currently recruiting. Cocoon is recruiting at the moment, I think, in 15 countries around the world, including about to start in India. So we're trying to have high and low income countries, try to recruit women in Pakistan and other countries that have been heavily affected by COVID. I know there are colleagues online doing research, working with Aboriginal and Torres Strait Islander communities to look at impacts, and of course migrant and refugee communities. There's also work going on looking at seroprevalence in pregnant women and looking at actual more biological implications of the virus for women who are affected. So an enormous amount of research. I think we do need to collate it all and have a register of research somewhere, but hopefully you can help us. One further study, just the issues around self-isolation and quarantine, and I think that's particularly critical at the moment. So there's a big study going on nationally called Optimise, which is recruiting pregnant and postpartum women, their experiences of self-isolation and quarantine. We don't think we give people enough information on how to manage that 14-day period and what it means, and hence some of the challenges we are currently seeing. So that's a study that's pretty live, providing information back to the health departments on how to improve those important periods. So Philippa, I might stop there, and I know we've got some really great questions coming, so I might hand over to you for the question and answer period. Thanks everyone.
Thanks, Caroline. Just apropos Cocoon 1, still collecting data, but we did have a tiny little peak at a very tiny subsection, and certainly there's an indication of women who've just given birth being concerned about and anxious about fathers and family members not being able to be with mum and bub for very long periods. So that's just one example of what we might be finding. So I think we're going to have a huge amount of very valuable data to look at and implement. So let's look at some of these wonderful questions. So there's one to Josh, wanting to know about the living guidelines process. Is it just specific to Australia or is it global? So I wonder if Josh could address that one.
Yeah, thanks. I've been trying to type some answers while we were talking. So the scope of the guidelines is very specifically Australia, with a couple of observations. One, about 30% of the web traffic is coming from international IP addresses. So we're definitely getting visitors from overseas. Two, as far as we can tell, this is the only example of a true living guideline process for COVID-19 guidelines. And we've had some approaches from other countries who are interested in sort of building off that or adapting it to their context or trying to set up a similar process. So that's been, I think, an important bit of, guideline methodology leadership that the task force has been taking. The third is more just a personal reflection that, I think the guidelines can be very useful to different settings, but one just has to think through explicitly questions of adaptation. That may pertain to health system arrangements, what drugs are available and where care is provided. But, there are methodologies and tools to help people adapt guidelines developed in one country to a different setting. And I am thinking more and more of our colleagues in the Pacific region who, may benefit from being able to adapt some of these recommendations to their context.
Josh, I wonder whether you could also talk about living guidelines more generally. You've talked a bit specifically about the ones you address, but I wonder if the question also might be about how common is the living guidelines process internationally?
Sure, yeah. I think the Australian Living Evidence Consortium has been one of the sort of driving groups of this internationally. So in Australia, there's examples of living guidelines in stroke, in diabetes, and other topics. But it has been used in other countries and in other settings. I have some experience with these methodologies. We've been applying it to WHO maternal and perinatal health recommendations for a while now. However, not quite at this tempo. And, I would just sort of say that, wherever we can ensure that the guideline products that people are using in clinical settings is appropriately responsive to changes in the underlying evidence. That's the goal that we're aiming for. That doesn't mean that every guideline or every country has to come up with a task force style model. And there are, I think, there are other examples of how to do this in a lighter way, but we're in a very unusual situation with COVID, and it has required this level of intensity to develop guidelines on a weekly basis.
Thank you. Now, there was one question which has disappeared, but I'll ask at any rate. So it was about breastfeeding, and I'll paraphrase. So I think it was something along the lines of, we've talked about breastfeeding, but what about if a woman is not breastfeeding? Shouldn't the same things be same criteria apply? So don't know whether Caroline or Claire wants to address that first.
Thanks, Philippa. Yeah, I just responded to Marianne on that one. Maybe I misread the question, but the comment is really about the question we were answering was, should women with COVID-19 breastfeed? And so that's why it's quite specific around the woman carrying the baby breastfeeds. And I can see what Marianne means about it not being, it's not saying breastfeeding carries a risk, it's the woman carries the risk, essentially. But it's, thanks for that, Marianne. We'll think about that one.
The future, some of the studies that are going on at the moment will address this as well. So yes, there at least two aspects to that question. So,
There are, the more you say it out loud, the more it becomes obvious that it's not quite as simple as you think.
okay, thanks. Shall we move on to question, if a pregnant woman has chorioamnionitis, use of antenatal corticosteroids should still be prohibited despite a woman having COVID? So I think that's clearly Claire's question.
I don't think chorioamnionitis should prohibit antenatal corticosteroids for any reason. I think that if you've got it for non-COVID related reasons, the baby still will benefit from maternal corticosteroids prior to birth, and that should still continue. There's no evidence that antenatal corticosteroids would be worse for a mother if she has chorioamnionitis. She obviously requires delivery. So I'm not entirely sure where that question's getting at. There was another question that came up about the use of antenatal corticosteroids and benefits to the baby and potentially to the mother. So in the UK data, I think it was about 60 or 80 mothers did receive antenatal corticosteroids for fetal lung maturation. And currently that data hasn't been looked at separately, but I know that they're planning on doing that to see whether there was any difference for mothers or babies in that group. Obviously, when that paper was published was prior to recovery coming out. And so that they're going to go back and look at that. And there's also a group from Birmingham that are going to try and do a bit of an IPD around that question and the use of steroids in general for fetal lung maturation and how that may be good or bad for the mother and the baby. But we don't have that information yet. Currently, it would be standard practice. We would recommend antenatal corticosteroids for the standard indications, whether the mother has COVID or not. The benefit to the baby is greater. There will be a statement we are working on that within the guideline committee. It's one of our to-dos, but the current practice would be that you should absolutely do standard practice, and that would likely be beneficial for both. Thanks,
Claire. Now we've got a question about the impacts of limited volunteer support services and Heartfelt, for example, having a drop in volunteers.
I can comment on
Caroline,
that, Philippa.
Would like to answer that? Lovely.
Yeah, so I think that was, the name's gone, I think it's Gavin. Good question. It's one of the areas in Cocoon that we're looking at for the most part, Gavin. So, and Fran's just said she'll touch on that next week in the webinar for bereaved parents. So hopefully more of that will come clear. Cocoon started, well, not really started, but it has a particular focus on bereavement. So a particular focus on women and families who've lost a baby during this period. And so the support networks is a critical part of the question. And the study originally came from our colleagues in Italy who, from Ciao, which is a organisation established around bereavement and stillbirth research. So that's sort of where that work came from. So I know that will come out. So I think it's a really important area. Also, all the bereavement traditions are kind of not happening in the same way, the support, but also being able to have funerals or memorials or people together or just the usual support that families need. So thank you for that question. I hope we can answer it.
Just to add to that, it's also drop in financial support
Yes.
as well. And I know Heart Kids here in South Australia, I can't remember the drop in donations, but it's very substantial. One we skipped over was about, yes, so just I might go back to Marianne Davey has come back to ask Caroline about bottle feeding COVID positive woman possibly carries greater risk and needs to use infection control. Did you want to address that again, Caroline?
Can I take it on notice and we'll go back to the task force on that one?
All right.
Thanks, Marianne. Really good point.
Sam Diplock from Department of Health has asked about how we're going to get the recommendations out to the wider world.
Yeah, it's a great point. Yeah, so Obviously, we're in a sort of slightly strange time here in Melbourne with the pandemic, but we've really been pushing hard on various dissemination and communication activities. So that includes, getting out there and ensuring that our communities of practice are aware of the recommendations through presentations, through webinars, through emails, through engaging with local champions at various health services. And at every opportunity, we're really looking to engage as strongly as possible with providers and clinicians who are working in health services where these issues are very real. I think by and large, working through social media has a huge impact. So really do encourage people to get in there and follow us on Twitter. But if people do see opportunities for us to come and speak more about the task force, they think it would be helpful to connect with their professional groups. We're always very happy to do that and have been doing so.
Okay, and a couple more questions. So research on COVID and late pregnancy, any intended research on COVID and early pregnancy to investigate teratogenicity? Maybe Claire, I think.
So that's certainly an area we're interested in as well. I think the initial data in terms of birth outcome data could only comment on people that were exposed during the third trimester, because obviously we need to wait 7 or 8 months to get the births from those that were exposed early on in pregnancy. So I think there's definitely an interest to do that. Our registry is including that information, so first and second trimester infections, and we're looking at surveillance during the pregnancy and ultrasounds as well as other birth outcomes there. So very important question. It's just a matter of having to wait for the pregnancy to get to a point where we have a birth outcome unless there's been an early termination or pregnancy loss. And again, that data is being collected. Pan-COVID is an international study which is primarily focusing on that, so not looking at the other questions about maternal disease, but more looking at the potential teratogenic risks. The other question that was raised and sort of feeds into this is also looking at fetal growth and the effect on the placenta. So there probably, as far as we know, is not a teratogenic risk, but there may be implications for how the placenta develops, and certainly whether there's appropriate angiogenesis and vascular development within the placenta, and that may not be happening properly, which may predispose to some fetal growth or preeclamptic phenotypes. And so probably increased surveillance for women that have been exposed early in pregnancy is warranted, although we don't really have data to support that yet. But more needs to be done, but yeah, that's why we want to capture the information so we can help to contribute to the literature.
Thank you. Caroline, you ready to address your breastfeeding question?
Am I back to the breastfeeding question? Sorry.
So there was a response from...
Yeah, so I agree with Marianne, and we'll take it back. I can't change it at this point clearly,
Okay.
but it's obviously a really important point, and we started just on breastfeeding because that was the main concern around should women be all bottle feeding, and that was kind of where it came from, the question, but we can relook at that. So thanks very much, Marianne, that's really helpful. There's another question I was going to comment on.
Yes, please.
Which I now have lost. The certificate of leave for women due to anxiety, and I don't really have an answer to this one, but I guess anxiety for all reasons is a reason that women can't work, don't go to work, need time off work, need to rest. Clearly in a COVID time, those additional things need to be considered. I know certainly in health services, staff who are pregnant are moved into non-clinical facing work, so back of house kind of work, and put in mask. Well, in Victoria everyone's in a mask, but careful infection control. So I don't know if Claire has any other views on this. I think anxiety is a really big issue at the moment. Certainly in the work we've seen so far, anxiety is huge for women in pregnancy.
Yeah, I think it is, and especially I think one of the challenges is the not knowing what's going to happen next week, and that's and how it will affect their care and moving forward, not just how the disease might affect them, but just how their care pathways might change. I guess there's two sort of areas to think about there. One is anxiety driven by that, and one is actually should they be working from a medical point of view, not to do with their mental health, but more to do with exposures. And as Caroline said, something in the healthcare worker advice is that no, they shouldn't be in face-to-face positions. And I think we just have to be cautious in terms of people like childcare workers. There's a lot of debate, I know, about transmission and things, but certainly for school teachers, a lot of them are now asking not to be in a face-to-face teaching role in places where there is community transmission. And then obviously there's been a change to mostly remote learning in Victoria, but not in every school setting. So I think it does very much depend on how many people they're seeing and what their potential risk of infection may be from community transmission, as well as addressing their mental health concerns.
We've got a question here about the observation of preterm births decreasing in Ireland and Holland. Should we be looking at starting parental leave earlier, which probably dovetails into what you've just been talking about in some ways, Claire and Caroline, perhaps?
Yeah, I mean, I think we don't have data in Australia yet to provide information about risk of preterm birth here. As I say, we're looking at it. It'll be interesting to see. I don't think we can comment either way on what's happening at a national level. I think it's actually an important question about parental leave, though, and that's certainly been a real challenge for a number of my patients in terms of those that have been in face-to-face roles, either in retail or teaching or other areas, and have chosen to finish work early and have therefore maybe not been entitled to government parental leave or parental leave from their employers, and some people missing out by a week, where it seems very disappointing. So I think there are areas that need to be addressed there. I don't think it's specific to the risk of preterm birth. I think it's more about how we're changing workplace practices in this time, but important to consider. It will one of many more subsidies that may be needed.
And on that note, the other side of the coin, the increase in, somebody's asked about the increase in stillbirth that's been seen in the UK. Do we have any feeling for whether this is happening in Australia as well? Any evidence?
Yeah, again, so we're working with groups to try and pull that data to find out about that. Obviously, the numbers are low, fortunately, in general, and so it needs to be a collaborative approach to finding out about that rather than looking at individual health services. But that's certainly within Victoria. We're trying to establish what's been happening here in the last few months. We're keen to connect with other groups, but we'll hopefully have that information before too long. And that sort of pans out to other things. So things like undetected fetal growth restriction and hypertensive diseases in pregnancy and how they've been surveilled. We do plan to look at all of that so that we can provide more information. Anecdotally, we don't appear to have seen a difference as yet. And obviously our lockdown has been different between different states and is very different from the experience from overseas. But very important questions for us to address in a timely manner.
Okay. You've got a response, Claire, to the use of corticosteroids if a woman has chorioamnionitis. It says, believe WHO overall and ACOG, specifically relating to late preterm birth, don't recommend the use of antenatal corticosteroids. Would you like to comment on that? So
I would not recommend the use of corticosteroids for late preterm birth, full stop. And I know there's some controversy there, but I think there's certainly the recent papers certainly come out with JAMA and looking at the effect of late corticosteroids on late preterm birth, and those babies that subsequently don't, and the risk of long-term neurodevelopmental problems in that cohort would make me very cautious about their use, not related to COVID. I think for the preterm, less than 34 weeks, corticosteroids should be recommended. And I think that's the guidance that we would follow in Australia.
Okay. One for Caroline Homer now. Is the ACM survey of women's experiences accessing maternity care part of the task force scope?
the short answer is no, because we are in the task force focused on women who have the infection, not everybody. So I know that ACM are feeding those data through to departments of health, both Commonwealth and state and territory. So there are other mechanisms to address the sort of broader issues, I think, and I know that maternity advisors and key people at each state and territory are working on that area. So really important data, and there'll be more to come, but we're particularly looking in the task force at women with COVID infection.
Mm-hmm.
I don't know if Josh wants to add to that. But.
No, that's fair.
We've got one here about data around undetected FGR or stillbirths due to telehealth and less face-to-face contact. Who would like to take that out of our 3-star speakers?
I'm happy to address it. I haven't seen the actual question, but I mean, it's definitely a concern that we've had, that the less face-to-face appointments have meant that some things have been missed. And so again, that's what we're trying to address, just to determine whether that actually has panned out in terms of outcome data. And I guess we're trying to do that in a timely manner so that we can adjust things as we enter second waves or third waves. But there's a lot of questions about whether there have been good things that have come from changes to telehealth as well as bad things, but each sort of centre has addressed it differently. And so that will be interesting to see how different models of care do affect outcomes. So some places have changed ultrasound schedules, not just antenatal care things. So lots to still be discovered, but it's an important thing for us to look into.
Good. Alison Morgan has given us an address for looking at some University of Melbourne research on health worker experiences. Alison, did you just want to? Oh, you can't really comment. You don't. I don't know. Does anybody else, one of the panelists, know about this research?
I don't know enough about it, but I know that Alison's team at University of Melbourne and a big group of people are doing some fantastic work around a range of issues around COVID, and talking to health workers, and some of them obviously are maternity health workers. So I encourage colleagues to look on their website. I'm sure that information's available. Alison's also made a comment about COVID stillbirth rates, and I've now lost it, but in Nepal, showing increased stillbirth rates during this period. So clearly a whole lot going on. But if you look at the website that you can see on the Q&A thing, that'll give us some more information, give people some more information. Sorry, I should know more, but I don't. Sorry, Alison.
The link is there. Thanks. Well, they were wonderful questions, and thank you very much for our wonderful speakers. A huge amount of information on this very challenging topic. I hope that everyone's got plenty out of what our wonderful speakers have transmitted to us, and we will have another 2 webinars to go. So webinar 3 is about bereavement care, and Fran Boyle and Jackie Mead will be doing that webinar next week, and then the week after that is the timing of birth webinar. So thank you very much, everybody. Wonderful audience, wonderful questions, wonderful speakers. So great job, everyone. Thank you for coming and sharing with us. See you soon. Keep in touch.
Thanks.
Bye-bye.
Thanks, everyone.